Good morning to everybody. Well, I'm not an ECMO addicted. Here, the population is very addicted to ECMO. So I would like to put some asking point. My duty is to raise in 5% of you some doubt about what we are doing and how you are doing. Well, let me start with the same slide that my friend Alain presented, which is, let's see, here, ECMO. We live in the triumph of the evidence-based medicine. So we put together a lot of experts, they look at the literature, and they found the evidence. And what is the evidence of ECMO? Zero. Not moderate, it's zero. Which are the recommendations? Please use ECMO. Why? Where are the opinions and where is the evidence? And you say, okay, you go ahead, just a few pages, you look at ECCOR. Please, ECCOR, get out. We recommend against the ECCOR2R. What is the evidence? Zero. So this should raise some, maybe at least some question. I know that most of you grow up with a randomized trial and with the epidemiology-based approach to science. My generation grew up with the physiology and with the mechanism. When I say, okay, ECMO improves survival, great. Why? Why should ECMO improve survival? Ask yourself. We don't cure anybody with ECMO or with ECCOR. We just take care of one symptom, which is the gas exchange, and we buy time. The healing is not due to the blood running in an artificial organs. This is a system to buy time, hoping that other therapies or other approach or making our intervention on lungs are less dangerous. So try to look at the things in a little bit this way. Let's see, here we have no, P-person, I don't like this one. Next one, great. This one we have Alan Combe, PaO2. Look here, PaO2 up here. Can you distinguish which are the treated and which are the control? I cannot. But everybody looks at oxygenation. I mean, we have exactly the same oxygenation. Look down, PCO2. Did you hear one word about the PCO2 and ventilation this morning? Everybody look at oxygenation. Everybody look at prone position without asking why prone position should work. In which kind of patient prone position should work. And this is based on physiology, not in a blind randomized trial that doesn't tell you anything about the mechanism. Now look here, this difference is crucial. PaCO2 is very clear. That means that ECMO, which is oxygenation, the real change has been done through the ventilation. And ventilation means PCO2. And then just to advance something, there are funny things as the ventilation in prone position. 3 milliliters per kilo. 3 milliliters per kilo, you ventilate the tube. You don't ventilate anything. Is a physiological nonsense. And if you ventilate with 3 per kilos, your lung, in a few days, become a piece of stone because of the absorption of telectasis. And all these damn guidelines and opinions do not take in consideration any physiological study on the topic, and we have a lot of them. Anyway, ECCOR2R doesn't work. Look, we have a beautiful study with Macaulay, and you have PO2 and FiO2. You know, ECCOR2R doesn't change, doesn't give oxygen. But oxygenation still is the same between control and treated. In the ECMO, oxygenation is the same. In extracorporeal CO2 removal, oxygenation is the same. But we love oxygenation. The intensivists love to have the red blood, right? Good. And oxygenation, since my friend Zeppel in 1975, the criteria of entry, since almost 50 years, are based on oxygenation, which is absolutely an ignorance of the basic physiology of the problem, of the approach to the problem. I know that I'm thinking, am I speaking not according to the usual flow, but this is a reality. And look, we have from Zeppel and Alan Combe study, the Olia study, the entry criteria were not very different, based once on oxygenation. And I told you that oxygenation is exactly the same in treated and control. So, if oxygenation is not related to survival, why we use it as a criteria? Because it was